everyone, this is Pranjal, and today I'm going to be speaking with Dr. Samantha Schindelheim, a licensed clinical social worker who specializes in working with young children, teens, young adults, and their parents who struggle with behavior challenges, self-esteem, relationships, mood, anxiety, trauma, and life cycle transitions. Dr. Schindelheim holds an appointment at Columbia University School of Social Work, where she's an adjunct assistant professor and teaches courses on advanced clinical practice and suicide assessments and treatments. I'm so lucky to have her here today, and I'm really excited to discuss the various forms of therapy with her. Do you have anything you'd like to add?
No, I think you covered it all, Pranjal. I'm just excited to be here and share some of my wisdom and be able to explain a little bit more in ways that can help your audience. So thanks for having me.
Okay, thank you so much for being here. The first question I had for you is, can you just tell me a little bit about yourself and about your work and what got you into it?
Yeah, sure. So I have been practicing for a little over 9 years now as a clinical social worker. I used to work in a hospital setting in what was called a home-based crisis intervention program. And I worked with children 5 to 18 who were in crisis. So whether that was a suicidal crisis where they're having thoughts of not wanting to be alive, or behavioral crisis where they were thinking about hurting themselves or other people. And so that really brought me to my passion in finding that I really thought it was helpful to be working with kids in particular who are having really acute concerns and didn't have the resources and support that they needed. So I did that for 7.5 years. And then after that, now I'm in private practice working with children, adolescents, and adults, as well as doing a lot of parenting work, which I love, working with parents on building their relationships with their children. When I got into social work, I was originally going to get my PhD in psychology, but I love social work more so in the sense that it really embodies the idea of social justice in the work that we do and thinking about the whole person, thinking about their entire environment and what's impacting them for having some of the symptoms or the mental health challenges that they're experiencing. So with that, I pursued social work instead and ended up getting my doctorate a few years ago, where I did some research on social workers who work particularly with Latina adolescents because they have some of the highest risk concerns for suicide, and understanding how the social and cultural perspectives can influence treatment and support the individual and as well as their parents in suicide treatment. So that's a long spiel of what I've been doing and why I'm interested in this work, but hopefully that answered your question a bit.
Yeah, it does. That's a very long journey. Congratulations on your doctorate.
Thanks so much.
I know you mentioned that you were working with children ages 5 to 18. Is 5 the youngest age at which we start seeing these kind of mental health issues? Because, I don't know, for me, it's hard for me to imagine that a 5-year-old would even have the cognitive ability to feel something like depression, or do they even understand death enough to be suicidal?
Yeah, it's a great question. Yeah, so kids start feeling immediately when we're born, right? There are some babies that are born who come out and they're calm and gentle and super, more sleepy maybe. And then we have other babies that come out and are very upset and crying and really hard to console. So we know, even from the mother's womb, that kids and children feel very early on. In terms of the age that I start working with kids where I see and would diagnose someone tends to be 4 and up. I don't love to put a label such as attention deficit, hyperactivity disorder, ADHD, or anything else before then, because we really want to understand the bigger picture. And even at 4 and 5 years old, I really don't like to put a diagnostic label either. I think that we can see, we might not understand depression in a young child, but we might see behavioral challenges or where they're acting out. And that can also be a form of sadness or a form of anger that then might develop into more of a significant concern toward depression. But for the younger kids, generally, when mental health is something of concern, it's around how are they behaving with their families? How are they behaving at school? Are they able to, be happy and enjoy moments with their friends, or are they constantly irritable and upset?
Yeah, I think you brought a good point about how even if maybe a 4 or 5 year old doesn't have depression now. If they have concerning symptoms, we should address them right away, because when they grow older, like left untreated, things are only going to get worse. So I think the early
Definitely.
prevention aspect is really important.
Yeah, yeah. And being able to, no matter what, I'm a big proponent on prevention of teaching kids emotions, being able to, whether there's an issue or not, in schools with parents to be able to say and understand what are emotions, what do we do with our emotions, how can we make ourselves feel good. It's okay to be sad, it's okay to be angry, and validating those experiences.
And I'm so glad this is becoming more common, because, like, when I was in elementary school, we never really talked about things like this.
Great. Yeah. And a lot of schools now have socio-emotional curriculums where teachers are either taught, or someone comes in, a social worker, to give a lesson on feelings or, mindfulness, deep breathing strategies, things like that.
So I know that one of the kind of unique things you do is you provide in-home therapy to clients.
Yeah.
And I was wondering, like, what are the pros of that? What are the challenges? Who is it good
Yeah.
for?
Sure, that's a great question. So I love in-home therapy. That's what I was doing with the home-based crisis intervention work. And I found that whether it's a crisis or whether it's long-term or, short-term therapy that's not in crisis mood, being in the home is beneficial to everyone. First, I'll start out with why it's so helpful for the families. So for the families, being comfortable in their environment is, I think, really ideal. Not having to journey to a sterile office where there might not be as much comfort and familiarity with this space to be able to express their emotions and feel comfortable in that environment. I think that's a big piece. I also think it can be really helpful for younger kids whose parents are really struggling with their behaviors to get them to go to my office. So being able to, for me to come to them, kind of avoid some of the hurdles, and brings me to my next point where I can see the child more in vivo in their natural environment. So whether it's doing a behavioral observation or being able to show a mother while a child's having a big tantrum and deeply feeling in those moments and needing support, I can coach the parent in telling them this is how we should manage this situation. For doing family work in particular as well, when there's so many players and getting everyone together is hard. So meeting them again where they're at in their home is really beneficial for family therapy work too. And I also think for teens, I do also walk and talk therapy or meeting teens in their community doing community work, because oftentimes, they're tired after high school. I can imagine you understand this, where you just don't want to have to go talk to someone and do therapy and all that. So I have some clients where some adolescents that I meet after school, and we take a walk, we go to a cafe, and I'm able to really meet them where they're at rather than having them come to me or having to meet them then after school at home. So we find that that's really beneficial too. The other thing that I think that you were tied to is that the challenges are there as well. I think some people might not be comfortable with me coming into their home, and that's understandable. And so having the option of doing virtual as well as working with me in an office is more helpful than in home, perhaps, for them. Another piece is also just that timing wise, people are so busy. It's hard to find a time where they're, solidly in their home space and being able to invite someone into their home. But I think overall, the more the logistics part is a challenge, and me having to commute and all of that. But in general, there's a lot more pros to in-home therapy.
Yeah, it's so
In my
amazing
opinion.
that you're offering so many. Because you're offering in-home, virtual, and in office. That's
Yeah. I
amazing.
don't currently have office space, but I plan to. Yeah.
Yeah, because I'm just thinking, like, back when I was a teenager, I think I would have really benefited from, like, in-home or, like, the walk and talk that you're talking about. Because, like, not only are you getting therapy, but you're getting outside and you're getting exercise.
Yeah.
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 I mean,
Yeah.
one challenge I can think of is a lot of my friends with online therapy, they have an issue of, like, their parents listening in,
Yes.
which, like, they may not feel comfortable talking in that case. But I think in general it's good to have more options. So
Yeah.
yeah.
Yeah, definitely. For adolescents, more so, unless we're doing family therapy where I need everyone together, I will generally suggest that let's go out of I'm in New York City, so out of your apartment and let's go for a walk so that, other people can't hear and that you have this space, in the park to talk to me, something like that.
Yeah. Because I have OCD, so I'm just thinking, like, if I had a therapist who was willing to, like, go outside and, like, maybe even be with me for the exposure therapy, that would have been amazing. And, like, it still
Yeah.
worked. Like the traditional therapy format still worked for me, but for people who are living somewhere where there's someone who's willing to offer in-home therapy, I think that could be a huge game changer. And I really
Yeah,
hope that maybe, like,
for sure.
maybe more people will take inspiration from you and this model will become more common, because I've never heard of it before and it sounds very promising.
Yeah, I hope so. And you also mentioned, I meant to mention exposure therapy. That's great. It's another reason why in-home therapy can be so helpful is, especially for OCD, where perhaps hand washing behaviors or other behaviors are so consistently happening in the home, to be able to do, relapse and response prevention and all of that is very much done in vivo in the home and can be very beneficial. Or I have a few, individuals I work with who have a lot of social anxiety and are scared to go up to someone at the store and ask for help or check out at the cashier. And so we will do exposure work around that. So that's where also the community work is done too.
And you work in New York, right?
Yeah, I'm in New York City.
Okay, so for anyone listening who's in New York, they can look into that.
Exactly, for sure.
And now I want to go into the actual different types of therapy. So I know one of the ones that you do is dialectical behavior therapy for adolescents, or DBTA.
Yeah.
I've heard of DBT before, but not DBTA. So what's the difference between the two?
Yeah, so the difference is in terms of a lot of the reasons for DBT, it's very similar, right? We're treating adolescents who are engaged in suicidal behaviors, have injuries, are struggling with other mental health problems that really threaten their safety. They're not functioning well in school. They have challenging relationships. So all that is very similar. The difference with DBTA is that we also involve their parents. And so there is a separate section. So with DBT, you have individual therapy. It's very comprehensive. So individual therapy, you get 24/7 phone coaching, you get your therapist is in a consultation group, and you get a skills group. And the difference between regular DBT and DBT for adolescents is that for the adolescents, it's called a multifamily skills group. And so in the multifamily skills group, the parents and the teens are learning the DBT skills all together with a therapist leading and facilitating the group. So that's one main thing that's very different. The other thing that can be really different is that the type of support might be more intensive in the sense that you might also get a parenting coach. Now, a lot of DBTA comprehensive programs provide an extra therapist to work with the parents on teaching them and learning their skills. It's almost like the child has an individual therapist, but the parents also have an individual therapist, but they work all on parenting and learning the skills and applying the skills to their daily lives to keep them toward a life that's worth living, is what we say in DBT. And then there's also an extra module. There's a module that's really focused on parent-child relationships, and that's called Walking the Middle Path. So that teaches parents and children how to create and find a synthesis to understand this idea of and rather than but or, that both can be true. The parent's perspective can be true as well as the child's perspective, and being able to find a better relationship through those skills. So that extra module in the skills training is part of DBTA and not part of regular DBT for adults.
Yeah, I really like the focus on parent-child relationships, because I think a lot of times with therapy, like, people tend to only focus on the patient, and with adolescents and children, we're so connected to our parents. You could make, like, all the progress in the world with us, but if afterwards,
Yes.
when we're done with the session, we need to go back to, like, a non-productive environment, or if the parents are, like, left out of the loop and totally confused, it's going to be a serious hindrance to any progress. So I think it's really nice that there's been this distinction between regular DBT and DBTA, and how adolescents have that, like, extra need for family therapy along with individual therapy.
Yes. Yeah, I'm a big proponent that if so much of the problems are stemming from the parent relationship, that, family therapy needs to be done. And also for younger kids, there's so much success more so with working with parents. And so there is DBTC, which I don't do, but there is a specific training and a specific therapy. So dialectical behavior therapy for children. So this tends to be the younger 7 to 11 age range, 7 to 12. And all the work is really done with the parent, teaching them how to help their child co-regulate and regulate and giving them strategies on behavior management. So that, is another piece to the work as well. You mentioned it's so important.
Yeah, and it makes a lot of sense because especially at that age, the parents are like the mechanism for change, not the kids. The kids aren't really the decision-making bodies.
Yeah. They're so morphed and changed and malleable based on how their parents are parenting them, right? And also I think teachers and schools. So I really work collaboratively and find it so important to understand how is the child doing in school, how are they behaving with their peers, all of that.
Yeah, that makes sense. And what about cognitive behavioral therapy? I know you also practice that. So could you just explain a little bit about what it is and who it's good for?
Sure. Cognitive behavioral therapy has been around for a long time. It was actually DBT is a type of cognitive behavioral therapy that was then expanded for more of the high-risk population back in the 90s. And CBT is really for a variety of mental health issues. I use CBT mostly for depression, anxiety, and other mood disorders, but it has been effective to show for eating disorders, for example. It's very much for, anxieties in there, so OCD. So it can be used as a treatment for many different mental health issues. And it's been effective in really helping create a better overall quality of life for individuals with negative thoughts, in particular, anxious thoughts. It focuses on changing your thought patterns, reframing the ideas that are in our mind, that are so ingrained in our mind, that really bring us down and cause depression or cause anxiety, as well as the behavioral, changing our behavior so that when we're, I have an adolescent who's sitting in bed all day and unable to go to school because they're too anxious, helping them to think about changing their thoughts as well as changing their behavior so that they're more successful in getting out of bed. So it really is, the goal is to gain a new perspective on your thoughts and emotions, understanding them, and then applying the knowledge of their challenges to change them. So it's really learning positive and helpful coping strategies to manage very difficult situations, such as not being able to go to school because of anxiety, or not being able to go and ask for help because of social anxiety, all the way to, challenges with eating and difficulty with the kind of your beliefs and your thoughts around how you should look or how you shouldn't look, and changing those.
So to clarify, CBT is more for mood disorders, like mild to moderate severity, and if things get more serious, like you're very concerned about like suicidal and behavioral problems, then DBT is better.
Generally, but to be honest with you, I use both in my work. I'm not someone who is strictly CBT for this person and that's it. There's so many wonderful skills in DBT and in CBT that I'm mixing and matching and wanting to get whatever is appropriate based on what you're telling me is going on. I'm going to teach you the CBT skill, or I'm going to teach you the DBTA skill. So really, the way I practice, because I don't have a full comprehensive team for DBT, is I'm teaching those skills anyway, and find that that's really effective. And some people might say, I teach holistically, or I'm more of a therapist that's eclectic. But really, it's just seeing what fits for the client. I don't think that one thing is the match.
Yeah, that makes sense. You don't want to limit a client to just one form of therapy when people are complex and their problems are complex. So it makes more sense to mix and match depending on the patient.
Exactly. Yeah, definitely.
Yeah. And I did CBT all throughout high school. And it really changed my life. So I would highly recommend giving it a try.
Definitely. CBT is a great form of treatment. And I think many people really want tangible skills when they're feeling helpless and alone and uncomfortable with so much discomfort with their mental health problems, that being able to have tangible skills that they can do and practice outside of the therapy sessions is really helpful.
And so the next form of therapy that I wanted to talk about was parent-child interaction therapy. I've actually never heard of this before. So, yeah, could you explain what it is and who it's good for?
Mm-hmm. Sure. So parent-child interaction therapy is generally the best for, I would say, anywhere between 3 to 7. There is a toddler model and there is an older child model. So the younger one can go, toddlers from 2, 3 years old. And then using the older child model is generally like 8, 9, 10. But what I generally do is we're thinking about 4 to 7 years old, general PCIT. And it's generally done or always done with the parent and the child together in treatment. So the idea is that we're coaching and we're teaching the parent how to interact with their child and how to manage some of the challenging behavior. So oftentimes I get a PCIT referral when the child is acting out at school or acting out at home. They're not following directions. They're having sensory processing challenges. And so a parent comes to me and says, I don't know what to do with my child. And oftentimes it's a relational issue. The child isn't feeling as connected to their parents, so they're acting out and they're not following directions. And the parent then gets frustrated and doesn't know how to respond. So the idea of PCAT is having coaching sessions during which the parent and the child are in a playroom while I'm in an observation room watching and interacting while the parent is interacting with the child in a one-way mirror or a live video feed. The parent will wear like a bug in the ear is what we call it, or headphones on, and we will call them to provide in-the-moment coaching on skills that they're learning to manage their child's behavior. And so the first phase of PCIT is the child-directed play, where the child leads the play. And it's really the goal of this part of PCIT is to improve the parent-child relationship. So when the child is in control, they have higher self-esteem. We see that they're proud of themselves. The parent is excited for them, and being able to interact in that positive way is really helpful. For the second phase, which is parent-directed interaction. So the parent leads the play and they're giving them commands and having them follow through with them. And then we take them to more real-life commands and give them harder things to follow through with, and eventually do it in a public space as well. Really, we see such improvement in this. We use what's called an ECBI, which is basically a survey that the parent fills out every week to see how concerning are the behaviors. And we notice, that it's going down, which is really wonderful, very quickly in the treatment in the first few sessions that the behaviors are improving. And then there's always like a check-in moment where we talk about how is the week, what's going on, to give the parents some advice and understanding around their child's and behaviors. So it's a really wonderful treatment. It's also wonderful that it's short term. It tends to be only 3 to 4 months with one session a week, which I think parents really like, in the sense that maybe not all of your child's behaviors that are challenging are going to go away. Kids are kids, but that the more clinically concerning level of behavior goes much further down and isn't as of concern.
Do you ever have parents come in with you and they have complaints about their child, and after listening to them, you're like, you don't need PCIT, this is all normal?
So I always say, I don't think any parent-child dyad could not benefit from PCIT. I would do it with anyone. I would do it with my own daughter and plan to do it with my own daughter when she's only 17 months. But when she's older,
Aww.
I think it is so helpful to do this type of play. And we give parents the homework to do this is called special time, the play time that they're doing, where the child is in charge. And they do 5 minutes of it every day where the child is fully in charge of the play. They're telling the parent what to do. The parent just watches them and engages them and also plays with them, whether side by side or doing one activity together. And we teach them what toys are appropriate for this type of play. And I just think it's so fabulous for any parent and child to do.
Yeah, and it sounds fun, honestly. Like playing with your child and being a child and getting that attention from your parents every day.
Yeah. And I find that parents are never taught really how to play. And that is such an important piece, is being taught how to play.
We've reached our last form of therapy, which is parent management training. So this is another one I haven't heard about. So if you could just, same thing, tell me all about it.
Yeah, sure. So parent management training is kind of a bigger umbrella of all of the parent-child work that can be done in treating more disruptive behaviors, more concerning acting out behaviors that we're seeing in kids. And it's, defined as an approach to treating child behavioral problems. It uses different procedures in which the parents are trained to change the child's behavior in their home, to make it more positive, to make it more adaptive to their environment. In this work, the parent is meeting with me only. So I'm working with the parent, I'm teaching them skills, I'm teaching them behavioral skills such as reinforcement plans. How can we, give the child a prize for certain behaviors that they're accomplishing? How can we, make sure that they're motivated and engaged and wanting to change their behavior? So it's really using specific procedures to change the child's interactions with the parent and also with the way they're behaving with other people in their lives. The idea is to promote pro-social behavior, so to get them to do the things that the parent wants them to do that are helpful in their daily life, that are important in growing, such as, let's say an 8-year-old who's refusing to sit at the dinner table, teaching them that we're going to, as a family, sit together and teaching the parent reinforcement strategies to get the child to do that, whether it's giving them labeled praises, such as you're doing such a great job sitting at the table with me, or having a sticker chart that's if they're sitting for 5 minutes, they get a star, and then they get another star for the next 5 minutes. And then when they get 5 stars, they get to have, a celebration, go to the playground after dinner, which they don't generally do, for example. So different prizes that we talk about as well. And it treats a broad range of child problems and populations, but it's really geared toward the pre-adolescent. So thinking about preschool all the way to school age. And those who are having temper tantrums, are aggressive, maybe they're excessively saying no, or, non-compliant with tasks. And it's shown very much to be effective in really helping the parent learn how to manage the child's behaviors overall. I do add an extra component around teaching the parent how to validate and emphasize and give empathy around their child's feelings, making sure that it's not all about getting the child to do what they want to do by creating sticker charts and reinforcement strategies, which are great, but also increasing, again, that parent-child relationship in playing with them and engaging and having a good time together.
Yeah, again, I think it's so great that it seems like you as a therapist really focus on educating the whole family instead of just treating the child, which, like, I know, like, my parents are going to love this episode because they always complain that, like, oh, your therapist never tells us what's going on. And of course you want to, like, follow confidentiality, but I think depending on the age, having some kind of combination of like individual therapy and family therapy and talking to parents could really be effective. And it's especially the younger they are, because that's when you're the most connected to your parents.
Yeah. Yeah. And I think the other piece that you're hinting to is the importance that the teen knows that I am supporting their parent and improving their behaviors. That the reason that, for example, a teen, I'm just saying, but for any child to know, you're not the issue here. It's a systemic issue here. Your parent is not the issue. You're not the issue. The whole challenge is around the system and the family. And that, together, everyone can get support. Everyone should be getting support. And that's really helpful for treatment and seeing success. A lot of adolescents are like, no, but the issue is my mom, it's not me. And that's why I think it's so important to also work with the mom, also work with the dad or caregiver, and teaching them and educating them about what's going on with their child. Perhaps why could it be happening? What's normal behaviors and what's not? All of that education is so important.
Yeah, that's a really good point. Because I think as humans, like innately, we want to feel good. We want the people around us to feel good. So the issue isn't in any individual. It's in like some like connection in the whole family unit or some like larger systemic issue. And if you only work with like one pawn in that system, it's not going to make a huge difference.
Exactly. We don't see much progress if we're not working with the whole system, like you're saying.
Yeah. And I think we already kind of talked about my next question, which was like, what kind of therapy is best for each client. Let me rephrase to see if I remembered everything. So PMT is good for like younger school-age children, because otherwise if they're a bit older, you want to work with them as well as the parents. And PCIT too, it's like with younger kids. And then
Much younger, yep.
Yeah, DBTA and CBT, you want to use them in a combination depending on the client. And in general, we really want to make the therapy personalized to the client rather than just trying to follow a textbook blindly and like sorting each client through categories.
Exactly. Yeah, definitely. And I will take and use PMT strategies when I'm working with a parent that maybe their child is doing DBT, right?
Yeah.
So I think there are what we call common elements and common factors throughout most therapeutic treatments, especially all behavioral treatments tend to have the same ideas and all the behavioral treatments. It's just talked about differently and maybe used a little bit differently, but they all have value and can be used together.
And is there any other piece of information that you think is important for our listeners to know before we wrap up this episode?
No, I think just that. I think it's amazing to keep promoting mental health and getting support. And really, I think we are in a period after the pandemic of mental health crisis among our country, in the sense that people need good care, really good therapeutic care, and need support. And it's really wonderful when people do reach out looking for the support, because it's clearly, such a need.
Are you taking more patients on at this time? If you are, I can like share the information. Some people listening might be interested.
Sure. Yes, I am. I'm only licensed in New York and New Jersey,
Mm-hmm.
but we also have someone on our team who can also as a psychologist and see people in different states virtually as well. And I do have some people available to fill my caseload. So would love to work with some of your listeners.
Okay, great.
If I would be appropriate.
Yeah, maybe I'll put your information in the podcast description or something like that.
Right.
Because it's so hard to find good therapy these days. All the therapists are like backed up for ages.
Yeah. There's also like a whole other conversation around insurance and out-of-pocket paying and all of that. That's such an issue with our system as well that makes it harder for people to get services.
Yeah, honestly, I should do an episode just on how to find a therapist, because I think some people get really stuck on that first step.
Yeah. And, I always say to people, like, it's okay to be looking for other to be interviewing me as a therapist, and other people too. You want to find the right fit. It's so important. And I think it's even hard to do that.
Yeah, it's hard to even have options to find the right fit. A lot of time it's like, well, they were the only one available.
Right. Yeah.
Thank you so much for making the time to speak to us today, Dr. Schindelheim, and thank you so much to those of you listening for supporting Not Another Depressed Teen. I hope this episode was as insightful to all of you as it was to me. And as always, feel free to email us at notanotherdepressedteen@gmail.com. If you have any questions, comments, or ideas, you can message us on our Instagram. And yeah, thank you all for listening today, and I hope you have a wonderful day.